Welcome back. Before we continue, we would like to express our heartfelt gratitude to Her Majesty, Queen Sofia of Spain, who's graced us with her presence here today. We are indebted to Her Majesty for Her Majesty's long-standing friendship, unwavering support to our mission of science and healthcare, and for her advocacy on behalf of patients and their families. Thank you. We just heard before coffee break about the latest drug-based approaches that can slow the progression of neurodegeneration. It's time now to talk about non-pharmacological interventions. Professor of Neurology and Clinical Pharmacology and Group Leader at University of Lisbon School of Medicine, Joaquim Ferreira will lead the discussion on therapies beyond pharmacology. Enjoy.
Thank you. It's really a great pleasure to be here, again, facing this really distinguished audience. And I'm a professor of neurology, I'm a neurologist, I'm a physician. I'm also a professor of clinical pharmacology, so my role as a clinical research person is to develop medicines for the treatment of the diseases, for the cruel disease that we are facing. So it's a little strange why a physician, a clinical pharmacologist, is sharing a session about non-pharmacological interventions. And in fact, the challenge is, as scientists, as clinicians, we are failing and having today the medicines that we would like to have. So facing the difficulty to having those medicines that cure or delay this disease, we need to, I would say, focus on other options, and the non-pharmacological interventions really in the past decades have gained a lot of interest, mainly because evidence now is, behind those type of interventions. So I will share this session. We will have 3 different scientific presentations. I would say that we will have 1 or 2 focused questions after each presentation, and we may, I hope we have time for a more long discussion at the end. So it's my privilege to ask for the first speaker to come to the podium, Professor Pablo Martínez, Lage, and his presentation will be successful adaptation of the finger model in Southern Europe from GOINZ-ZAINDU pilot study to the CITA Go-ON trial. So we are really, anxious to hear about your results. Thank you.
Thank you so much, Joaquim, for your nice presentation. Buenos días, señora. Buenos días, good morning, everyone. I want to thank Pascual and all the people at the Fundación 100 and Fundación Reina Sofía, and of course at Fundação Champolimot for inviting me and giving me this chance to share our experience in trying to face some of the challenges that epidemiology is placing on us beyond those related to pharmacological therapies in this field of cognitive impairment and dementia. I don't have any conflicts, I guess, with the content of this presentation. I've received honoraries and financial help from ESI and Lilly and Grifols and Roche and Novo Nordisk. A few years ago, in 2012, we started a longitudinal project, a longitudinal study, trying to understand better the preclinical phases of Alzheimer's disease. We were able to recruit a cohort of 400 people, and we collected a lot of information and data on them, including CSF biomarkers. And one of the things that we did in these people is administer the well-known CHAIRPERSON dementia risk score, which you all know, and as you all know, places a lot of weight on what has been traditionally called vascular risk factors. I prefer to call them modifiable risk factors. And my colleague, Miriam Ekai, made a study focusing on cognitively normal people who had high CHAIRPERSON dementia risk indexes, so who were at increased risk of dementia. And even though they were cognitively normal, they show some cognitive impairment, or they show lower cognitive performance in memory, in executive function, and also visual perceptual abilities and constructive abilities. And what Miriam showed is how memory is very related to amyloid and ApoE, but the other functions, visual perceptual and executive function, are related to A-beta, but also to white matter hyperintensities, and tau and phospho-tau. So we start to see a relationship of what has been traditionally called vascular and neurodegenerative and vascular lesions in the brain. Other colleagues also try to understand the relationship between blood pressure and vascular risk indexes with CSF biomarkers of tau and amyloid, and also to investigate how plasma lipids, cholesterol, and triglycerides are related to some changes in the microstructure of the white matter, and how these changes are related to axonal neurodegeneration as measured by CSF neurofilament. So again, something that we usually relate to the vascular wall, such as cholesterol and triglycerides, seems to be related to neurodegenerative markers as well, and not through vascular mechanisms. On the other side of the coin are protective factors. My colleague Ainara Estanga in this cohort showed how people who use Basque and Spanish language on a daily basis, who are supposed to have a higher cognitive reserve, show lower levels of tau and phospho-tau in the CSF, much lower prevalence of amyloid pathology, and of course, better performance in some cognitive tests. And if we talk about physical activity, and especially physical fitness, we have seen that people who have a higher physical fitness show lower levels of tau and phospho-tau. And in these people with higher physical fitness, the relationship between phospho-tau and amyloid, and phospho-tau and a marker of inflammation such as YKL40 is lost. So it seems that these protective risk factors might be doing something to the pathology that we usually relate with Alzheimer's. So even though we really don't know the mechanisms underlying the action of these factors, I think the chances are high that these modifiable risk factors and protective factors might be playing a role in this model of dynamic changes in the pathologies and biomarkers. They might be playing a role at the onset of the cascade and the rate at which the cascade develops, and most importantly, in the way that the cascade and the pathology manifest clinically. So with this new movie of Alzheimer's that we have, Alzheimer's is not a type of dementia. Alzheimer's can cause dementia, but before dementia and dependence, it causes a lot of other symptoms that we can identify. And as you all are imagining, and you all have already thought, the window for prevention is really attractive. As I said, we have had the challenge from the epidemiology telling us that if we delay symptoms 5 years, then the prevalence might be reduced to a half. And now we have this even harder challenge from the experts in epidemiology telling us that 1 in 4 or 1 in 3 cases of dementia, of dependence due to brain disorders, might be preventable. You know how the Lancet Commission has really reviewed, and on the basis of many meta-analyses and review works, what are the modifiable risk factors related to dementia. But of course, the main point is identifying people who are at high risk, people in whom we could do some interventions. And this is what we did while we were doing our Gipuzkoa Alzheimer project on preclinical Alzheimer's. We made a study in a small city in Gipuzkoa called Deba, trying to see the prevalence of preclinical Alzheimer's and prodromal Alzheimer's, but we took advantage of the situation to also investigate the prevalence of increased CAIDE dementia risk scores. And as you can see in the population of Deba, 20% of them showed increased risk of dementia. While we were doing this study, the mayor of another city in Gipuzkoa, which is called Beasain, called us to ask, hey, I want to do something about Alzheimer's in my city too. We already have roads, we have squares, and so I want to do something for Alzheimer's. What we proposed him was that instead of doing a research project such as in DEBA, we proposed him to carry research to the streets, to the houses of people. So we tried to set up an early detection program. We did a raising awareness campaign. As you can see, a lot of talks given. We reached like 1,000 people of the 4,000 inhabitants older than 16 by assigned at that time, to tell them about Alzheimer's, to tell them how Alzheimer's could be diagnosed early, before dependence, to tell them about risk factors, to tell them that anyone could know the risk profile, his or her risk profile, and do something about it. And after this campaign, in this population, which I like to say were somehow empowered as they were well informed, the percentage of people with increased CAIDE went up to more than 40%. As you know, some studies in Europe have shown that doing something about risk factors and doing something about physical activity, exercise training and things like that had shown not so good results. This is a MAP study in France, and also the PREDIVA study in the Netherlands had been negative. But as you can see in the MAP study, which included a multi-domain intervention and also supplements of omega-3 fatty acids, sub-analysis and post-hoc analysis showed that even though the study was negative, those who had increased risk and those who had evidence of amyloid pathology, in these people, that multi-domain intervention had an effect. And in 2015, the FINGER study was published showing that a multi-domain intervention of risk factor control, cognitive training, physical activity training, and diet change was efficacious to prevent cognitive decline, or even to improve cognitive performance in people who were at risk because they showed increased CAIDE risk indexes, and people who were at the edge of cognitive impairment, showing what we might call, I know this can be discussed, cognitive frailty. So we had a population with many people with increased CAIDE risk scores. We had the results of the FINGER study, so we decided to carry out a study to see if we were able to adapt the FINGER methodology to the social and cultural and language context of the Basque Country. And this is the GOINZ-ZAINDU study. GOINZ in Basque is early, ZAINDU is care, so it's about caring early to prevent cognitive impairment. And we had the people, we had done the early detection program, so we were able to recruit 120 persons, fulfilling this inclusion criteria of increased CAIDE, who showed either cognitive impairment or low performance in some brief cognitive testing or the 88 questionnaire. 60 of them were randomized to receive a multi-domain intervention, another 60 to receive the standard health advice with their primary care physicians and nurses. So this is the intervention that we designed, including diet changes, cognitive training. With cognitive training, we realized that there were a lot of materials for people who already had cognitive impairment or dementia, but no materials to do cognitive training in a preventive fashion for people with normal cognition. So we had to develop our own materials. They received periodic visits with their primary care teams to control risk factors and to receive the diet advices every 3 months. And as I said, the control group who received the standard care. The objective of the study was feasibility, so adherence was our main outcome. And we can say that more than 70% of the participants showed high or partial adherence to the intervention, which we think it was a success of the study and showed really that the study and the FINGER methodology could be feasible and applied in the Basque Country. And as a secondary outcome, we looked at efficacy. And even though it was a small study, we were able to see that the multi-domain intervention had an effect on delay on reducing the risk of getting worse in executive functions and also speed processing. So with a successful pilot study, we were kind of happy and forced to go on to design and carry out the large efficacy study. And this is what CITA GO-ON study is. GO-ON works very well in English to say that we are continuing with the prevention strategy, but also comes from go of goiz, and on in Basque that means good. So on, early, good, to prevent cognitive decline due to Alzheimer's, vascular pathology, whatever. We were not able to do this alone, so we were able to reunite a consortium of different centers, taking charge of different parts of the study. And we had the data from the pilot study to calculate our sample size. This was the big challenge, recruiting 1,000 people with this inclusion criteria, increased CAIDE, and as I said, cognitive frailty. This time we define it as having significant subjective cognitive complaints and or low performance in one of two brief cognitive tests. Exclusion criteria were the usual, having already dementia, dependence, pathologies that could prevent someone from participating in the study. So these 1,000 people would be randomized based on age, presence or absence of cognitive impairment, and sex, to either receive the multi-domain intervention or receive recommendations about how to take care of oneself in relation to active and healthy aging and control of risk factors. So everyone in the study received recommendations, but those in the group who would receive standard care would be, so to speak, left to take care of themselves together with their primary care teams. And the group that was randomized to the intervention would be seen every 4 months to control for blood pressure, cholesterol, weight, BMI, and so on. As I said, visits that they would receive every 4 months. So the intervention, it consists of a cognitive intervention with workshops that are administered on a group basis, together with some exercise to be done at home. This is done by us from CITA, in CITA Alzheimer's. There's also a socio-emotional intervention that was not included in the finger study, but we really saw in Beasain that we had to include this. And again, this is administered in workshops, and also some work to be done at home. This is done by the Qualical group at the University of the Basque Country. The physical activity training is based on the BB-Frail system, so it's kind of a tailored program to do exercise regarding strength, stability, and also aerobic exercises. The nutrition and diet intervention will be carried out at the Basque Culinary Center, where, as you probably know, many of the famous Basque chefs are teaching. So the program is not only about telling people which are the good and the bad foods, but also to tell them how to cook them and how to make them attractive. And also the intervention includes, I think I've gone through all these, activity, cognition, diet, and risk factors control. Yeah, sorry about that. I don't have time to go in detail through all the parts of the intervention, but our primary outcome is cognition. It's a neuropsychological test battery, the same one that was used in the finger trial. And we also have some secondary outcomes regarding cost effectiveness, psychological outcomes such as depression, anxiety, functionality, and some other exploratory outcomes related to neuroimaging and biomarkers. And of course, secondary and exploratory outcomes related to each of the interventions. Recruiting has been a great challenge, especially if we think that we are a single center. Other fingers around the world do have like 6 centers in the Netherlands study, 17 centers in the Latin American study. We are a single center, and I'm proud to say that we have made the job, and we have finally recruited the little bit more than 1,000 people that we need for the study. As you can see, we had to reach a lot of people to make them interested in the study, they were invited to enter an online questionnaire where they gave information that allowed us to calculate a CHAIRPERSON index risk. So it's an online CHAIRPERSON risk, which correlates very well with the on-site CHAIRPERSON risk. And as I say, people enter the online, we were able to pre-select them, carry them to have the screening visits. As you can see, we've done more than 2,000 screening visits to be able to screen this more than 1,000 people. This is the status of the study. We have had to divide it in 4 waves. So wave 1 has already concluded the study. We've done the 24 months follow-up visits, and we are very happy to see that the discontinuation rate is lower than 10%. The second wave has already finished the 12-month follow-up visit this month. The third wave was randomized and started the intervention in June, and the fourth wave will be randomized next month in October. So we will have results at the end of 2026. So far, things that we can say and share with you, for instance, in recruitment and with the baseline data that we have, there are some gender differences regarding the baseline variables. It seems that women are more interested in participating in trials than men. As you can see, people who fulfill the online questionnaire, there were more than 60% of women. But when it comes to being recruited, because women maybe perform better in cognitive testing, they are less recruited. So if someone is going to design a new finger study, this might have to be taken into account. We have been able to get funding to do sub-studies. This is a program from the industry department of the Basque country that has funded us to do blood-based biomarkers and neuroimaging analysis and apply these delta H indexes with techniques of artificial intelligence and big data analysis. We're going to be able to do metabolics and microbiome pre and post intervention, and also the digital biomarkers. And we are very happy to have received also funding and collaborate with the group of Alberto Yo and the group of Maite Mendioros in Pamplona to face this challenge of showing that if it is true that epigenetics are related to environmental factors, we want to check if by intervening some of these factors, we are able to change the epigenetics of memory. And at the same time, we will try to investigate to what extent, if we see an effect, that effect is related to amyloid mechanisms, tau mechanisms, vascular mechanisms, inflammatory mechanisms, as analyzing altogether biomarkers, imaging data, and epigenetics. And this funding has allowed us also to include sleep disorder as a risk factor, which is not that easy to really ascertain. We've been able to do sleep monitoring studies with wearable devices. And we are very surprised to see that there's a lot of people out there with severe sleep apnea syndrome who not only they don't know about, but who apparently show no symptoms of it. So there's no correlation between the presence of sleep apnea syndrome and scales measuring somnolence or quality of sleep. So that's a big challenge. So to finish, our study is not the only one. It's included in the big worldwide Fingers initiative that was promoted from the Karolinska Institute and the Alzheimer's Association. This map should be updated since Portugal, which appears in white, should be now in blue, as there's an initiative here in Portugal to start a finger study too. So thank you so much for your attention. Gracias, señora. And thank you, of course, to all the people at CITA Alzheimer. Thank you to Mia Kivipelto and Francesca Mangialaschi for all their support in the design and the carrying out of the study. And of course, thank you so much to our funders. Thank you so much.
Thank you, Pablo, and congratulations for the amazing work. I really envy you having access to all that information. So I think we can have one or two very focused questions. I start, I think we are suffering a little bit for the classical neurological divisions, cognition in one side, movement gait in other side. And now what you are trying, it's a little what we call dirty intervention, dirty interventions, nutrition, exercise, the affinity, it's really low. It's really, I would say, we are targeting the brain in the good sense. So the question is, you are still using as primary outcome cognition and still recruiting patients a little bit in a broad way, but very focused on cognition. Shouldn't we move to things like, gait impairment, global slowness of movement? So shouldn't we move to a more, because cardiovascular risk factors really cause not just cognition in terms of impairment, it's bradykinesia, it's gait disturbance, it's behavioral changes. Shouldn't we move a little bit for a more broad type of, recruitment strategy and also outcome?
Absolutely, absolutely. Yeah, the brain does much more than just cognition. And gait, I totally agree, that is something to be taken into account. We are kind of measuring gait with some scales like the Tinetti scale, and my colleagues at physiotherapy are also doing tests mixing together walking and thinking, which is a measure that might give a lot of information of how the brain is working. But I agree with you that, well, we all know from neuropathological studies that people who have cognitive impairment / dementia show amyloid pathology, a lot of vascular lesions, a lot of vessel wall lesions, some synucleinopathy. So I think that with these multi-domain interventions, we are kind of trying to face part of those pathologies, but most probably not only one.
Thank you. So probably I would invite you to join, to sit here, and then it's my privilege to ask the second speaker, so Professor Giacomo Koch from the Foundation Santa Lucia, Rome, Italy. So now we move from Spain to Italy, and we also move to another type of non-pharmacological intervention. So the title of your presentation is Personalized Neuromodulation of the Default Mode Network for Treatment of Alzheimer's Disease, Foundations and Next Steps. So please.
Good morning, everybody. First of all, I would like to thank the organizer, Fundación CIEN, Fundación Champalimaud, and Fundación Reina Sofia. This is really an honor for me, and congratulations for organizing such a great meeting. So my task is to actually introduce a different topic. I will talk about neuromodulation in Alzheimer's disease and how non-invasive brain stimulation may actually be a potential target. Now, we have to introduce now a slightly different framework. So, of course, if we speak about Alzheimer's disease, we have to refer about the underlying pathology. We know how important habitat deposition is, how much it is interrelated with neuroinflammation, tau deposition, and this very complex and poorly understood cascade of events. Actually, what it does, it results in harming neuronal functions. And especially what it happens is that there is some sort of compensation for several years. After a while, synaptic function starts to decline. And that's exactly when cognitive symptoms arise. So why we think this is an important window on the disease? Because we can use neurophysiological methods such as non-invasive brain stimulation, electroencephalography, neuroimaging, and so on, actually to track these changes, to understand what's happening at a single patient level in the brain of a patient with Alzheimer's disease. And then, based on this knowledge, we can build new therapeutic interventions. So the idea is that, of course, the disease starts at the neuronal level. We know how profound can be the damage in terms of synapses, in terms of local circuits, and then after a while there is a clear depopulation of the number of synapses in the circuit. But at some point, what really matters in terms of clinical aspects is that these local changes and disruption of synaptic activity is translated more broadly to a neuronal circuit level, and then when it becomes even more affected, there is a disconnection between different area in the brain, and the connection between the areas in the brain is very relevant for higher order cognitive functions such as memory, attention, and so on. So we and others are now trying to transfer the amount of information that we got from basic science in terms of neurophysiological changes affecting synaptic activity into the clinical ground. So let's start with some foundation, which are the most relevant pillars of synaptic dysfunction in Alzheimer's disease. Well-known excitatory inhibitory imbalance, hyperexcitability. We know that actually in course of AD there is a profound change in the excitability of the neurons that at the beginning starts to be hyperexcitable, but during course of the disease it can become hypoexcitable. And this is clearly an important mechanism that is probably mediated by glutamatergic transmission, but it's not the main topic here. So the other thing that is very relevant, the other neurophysiological change that occurs during Alzheimer's disease is disruption of gamma activity. What is gamma activity? It's a high-frequency oscillatory activity that makes neurons work together at a certain oscillation around, let's say, 40 to 120 hertz. And this actually fast gamma activity is related to higher cognitive function and special memory. And it's well understood because it's supposed to be mediated by a certain subtype of interneurons, GABAergic parvalbumin positive. The other very important thing for the purposes of our talk is the impairment of cortical plasticity. So we all know how much memory is actually linked to the properties of the brain to be plastic and to form new connection, new synaptic connection. And one neurophysiological tool actually to explore and to determine the amount of plasticity is the determination of long-term potentiation or long-term depression, which is related to forgetting, which is also another important aspect. But it is well known since in the past 20 years or so that in models of Alzheimer's disease, animal models of Alzheimer's disease, long-term potentiation is clearly disrupted, and there is, on the other end, a shift towards long-term depression. And this has been also been put in touch with the underlying amyloid and tau pathology. And finally, if we put these things together, then we come to a broader vision in which all these changes may actually affect network. And in the case of network dysfunction, it's not only diffuse, but there are some networks that are more affected than others. And this is because the position of pathological hallmarks such amyloid and tau are preferentially, since the early phases of the disease, localized in areas of the so-called default mode network. And the default mode network is very important for several cognitive functions, such as memory, attention, and also the ability to relate with other people, with the environment. So this background actually is important because what we want to do by using our neurophysiological tools is to determine a single patient levels, which are the abnormalities, and then again try to have two sort of outcomes. On one end, we actually use this information as a biomarker of synaptic dysfunction, and this could be important for several, say, clinical trials, even with drugs. On the other end, we can use this information to build new therapies based on non-invasive brain stimulation. So in the first part, I want also to introduce a few ideas about how development of new technological methods, such as TMS in combination of EEG, can be relevant, because in the past few years, the field has been limited by the fact that, for instance, transcranial magnetic stimulation, which is a very precise way to test synaptic activity in healthy brain, was limited mostly to the exploration of the primary motor cortex. It gave us very important information, but especially was limited there. But of course, we know that in Alzheimer's disease, we have much broader complex dysfunction across non-motor areas, of course, associative areas such as the parietal cortex, the prefrontal, and the precumbent. So the use of TMS in combination with EEG, to technically challenging, is very important because it gave us the opportunity to measure different aspects, including excitability, oscillatory activity, and connectivity. So just few examples on how this technique and this approach can be used in patients. And in fact, we recently published a large series of patients in which we show robust evidence of hyperexcitability, which was regional, right? It was not widespread, but was more pronounced in areas such as the precuneus and the posterior parietal cortex as compared to the prefrontal cortex. And the same methods was used to determine whether patients with Alzheimer's disease may have actually an impairment of gamma oscillation, and this was the case. This is what we found in this study. And again, we were mapping different areas of the brain, and the results were different according to the site of stimulation. In this case, the prefrontal cortex was the area that was showing most affected gamma activity, and importantly, it was nice to see that actually the frequency that we found more affected, around 40 Hz, was exactly the same that was found in animal models. And then it's important to add another level of confidence here, because we were analyzing a large sample of patients so that we were able to see how much also this measurement can be important and associated with clinical impairment, and can be used actually to predict subsequent cognitive decline in these patients. And then the other pillar of synaptic dysfunction is impairment of cortical plasticity. And again, we can use other protocols of repetitive transcranial magnetic stimulation to measure LTP impairment in patients with Alzheimer's disease. And this is what we and others have been doing in the past 10 years or so. And the results are actually very robust. So there is a clear impairment of long-term potentiation. There is in patients with Alzheimer's disease, you can see it's almost impossible to get a strong long-term potentiation. And again, this long-term potentiation impairment is strongly associated with the level of cognitive impairment and can be used clinically to predict the speed of cognitive decline in the next 18 months or so. And so the other aspects that we want to focus, it's very relevant then for building a therapeutic approach, is mapping of connectivity. If we stimulate the brain with a single TMS pulse here, we can evoke large series of waves traveling in the network that we stimulate. So in this case, it's the precuneus, the formal network. And as you can see from this slide, there are clear differences between ALT controls and patients. In fact, we were recently putting all these data together, and we were able actually to determine how much there was a robust breakdown of TMS-evoked EEG signal propagation in the brain of patients with Alzheimer's disease as compared with ALT control. And using this source analysis, TMS-EEG data, it is possible actually to map precisely when and where in the brain the signal is disrupted, right? We can then map this TMS-EEG connectivity patterns with fMRI to actually confirm that we are engaging the formal network, and it is also important to combine this with structural MRI because we can get information about which are the white matter pathway that actually conveys the propagation of the TMS-EEG evoked activity, and in this case was the cingulum, as expected, but not the corpus callosum. Anyway, the next step then, now that we know what can we measure in these patients, it is important to keep in mind that every brain is different, and so we want to actually take advantage of mapping of TMS-EEG activity in each patient. So we are building a new framework in which we are going to stimulate several spots around the area of interest, in this case, the precuneus. And as you can see, depending on whether you stimulate, these spots are separated by just 1 centimeter. Is it possible to obtain different local measurements and, of course, different engagement of the entire network? So what you can do is actually build a sort of heat map, and a single patient level, you can determine which is the spot that activates better the network. And this is important when we want to transfer this into a therapeutic approach in which you're going to use TMS actually to engage the network in the long term, as I'm going to show you later. So this is just one example of 3 different patients. As you can see, the pattern of propagation of the signal is pretty different. And within these patients also, depending on where you stimulate, you can get different responses. So it's quite complicated, a lot of data, but we think these are a relevant step forward in order to make a real personalization of therapy. So second part of the talk now, based on the information that I gave you, on the fact that we have some knowledge on how we can actually measure alteration of synaptic activity at single patient level. I mean, in the past 15 years or so, I would say there has been an enormous interest in considering whether cold magnetic brain stimulation actually help people with Alzheimer's disease. Can we transfer this knowledge at a clinical level and use the capability of non-invasive brain stimulation to counteract synaptic dysfunction? Of course, there are several methods. Our preferred is repetitive transcranial magnetic stimulation, which is supposedly the most robust technique able to boost plasticity in the brain, but other methods such as ultrasound, electrical stimulation are currently under investigation in clinical trials. Why should non-invasive brain stimulation and especially RTMS work? Because there are several evidence showing that, of course, RTMS may increase brain plasticity, so will counteract LTP deficit, may increase gamma activity. We mentioned before how this is important for cognition, and network connectivity. Of course, what we know is, in fact, from combined studies with using TMS and fMRI, is that if you stimulate a certain area, you're not going to change only local activity, but you're going to engage the entire network. And for the purposes of the current approach, this is very relevant. Interestingly, now several experimental studies are performed in animal models, and actually these are showing that if you use RTMS in animal models of Alzheimer's disease, you may actually increase long-term potentiation, and there are also evidence that there are a cascade of events that may involve also inflammation, anti-inflammatory molecules, beta deposition, tau, and so on. But in general, I think this is promising, but because it's actually confirming what we are hypothesizing at a system level. Now, very briefly, just to summarize what has been done in the past few years, so people tried to target different areas of the brain in order to improve cognition, and especially the dorsolateral prefrontal cortex and the temporoparietal cortex were the preferred target, right? And this is also a legacy of the field because RTMS is approved as a therapy for depression when stimulating the dorsolateral prefrontal cortex. So I think this is the reason why most people tended to land here, while I mean the background clearly indicate that the full mode network is the most affected network in the disorder since the early phase. Anyway, so one just to mention this because most studies were targeting different areas, and especially what was lacking in the field is that these studies were short-lasting. So few weeks of stimulation and then try to see what was happening in the brain in terms of improving cognition, but just for a short term, right? And so this is just to summarize the results. So in general, this is a meta-analysis showing that we can say that RTMS is favorable in terms of cognition, independently where you stimulate, how long you stimulate. It's probably more effective than TDCS, which is uses electrical fields and is less powerful. But again, the limitation of these studies is where they're not probably targeting the right network, and especially they were limited by a short-lasting period of time, while we know that neurodegeneration is a very slow process when we deal with clinical trials with drugs to show an effect. Now, these drugs are used for at least 12 or 18 months. So we focus on the full mode network. Again, a lot of evidence continuously supporting how early this network is affected. And within the full mode network, the precuneus is the most common area of dysfunction, and it's clearly an area in which amyloid beta and tau are strongly damaging the network. So this was the rationale for us to actually build this new model of the formal network TMS in adult patients and try to transfer this into the clinical trial. This is the first study that we actually published recently, in which for the first time, actually, we inserted ERTMS as a therapeutic tool as if it was a drug. So it was not just a short-term effect to show improvement in cognition, but we wanted to see whether continuous application during 24 weeks, starting with a 2 weeks intensive phase and then keeping a weekly stimulation session for up to 6 months, was actually able to counteract cognitive and functional decline. At the same time, in the studies, we introduced another source of novelty because we use TMS-EEG personalization, as I show you. So every patient had different parameters of stimulation according to the individual features. And again, another source of novelty, we decided that targeting the DMN is probably the best thing to do. So these are the results that we obtained. Sorry, just very briefly describe the study. 50 patients randomized, 25 allocated to real TMS and 25 to sham. We just lost few patients, 3 and 2, and the therapy was very well kept, minimal side effects. So these are the results, and what we actually were seeing, the primary outcome measure was CITA sum of boxes. We also use ADAS-Cog, mini-mental state elimination. ADCS-ADL is very important because it measures functional independence, how a patient can be autonomous in his daily life. NPI and frontal assessment battery, we use this scale as a control because it's related to frontal lobe function. But in general, we found that there was a clear separation between patients treated with ERTMS as opposite to patients treated with sham, which tended to decline. And we were happy to see that this separation were actually involving not only cognitive functions, but also the autonomies of daily living. So overall, these patients were we were preserving their cognition, but also preserving their autonomies of daily living. And then we used TMS-EEG to monitor the effects on brain activity, and we found actually there was a stabilization in the network, there was a robust increase in gamma oscillatory activity, and there was some correlation between these neurophysiological parameters and clinical gains. Recently, we also published a study in which we were using structural MRI and functional MRI to see how therapy was actually changing network connectivity and the integrity of the gray matter, and we were seeing that there was an increase in functional connectivity within the formal network, and especially we were happy to see that in the network that we stimulated, there was a reduced atrophy as compared to patients treated with sham, and there was also a preserved microstructure of the cortical columns in the same area that were stimulated. And this work was done by Lucia and in my lab. So very quickly, just to extend this, we are now extending the duration of the treatment up to 1 year, and we're going to present preliminary data CITA that are showing favorable effects up to 1 year against CITA sum of boxes and other cognitive and functional scales. So to summarize, I hope that I convinced you that TMS combined with EEG can be used as a novel biomarker of synaptic dysfunction. We mentioned cortical plasticity, hyperexcitability, gamma oscillatory activity, and DMN connectivity as the most promising measurements. So the idea is that TMS, of course, may slow down cognitive functional decline, but personalized cognitive brain stimulation is the key and could represent a novel therapeutic approach in the patients. So what we have to do now, we have to actually implement our neuronavigated TMS-EEG personalization that needs to further validate and automatize in order to be used broadly. Of course, we need confirmatory multi-center phase 2/3 randomized controlled trials to validate the potential of this approach, and we also need to understand better what's happening. We're going to use CSF imaging and plasma biomarkers, beta amyloid tau, neuroinflammation, and especially synaptic activity to try to correlate these effects on synaptic function with underlying pathological mechanism, and also need to investigate genetic influence. We have some preliminary evidence showing that probably ApoE matters here. So I would like to thank all my collaborators in Rome, Ferreira, Of course, I would like to thank all the patients, the families, and the foundation that make this work possible. And thank you very much for your attention.
Thank you, Giacomo, for the interesting data and amazing results. So we have time for one or two. Yeah, John, please. Can you bring the microphone, please?
Really interesting. And one of the things, if I'm seeing your plots correctly, is you seem to see the preliminary data for 52 weeks seems to show continuing divergence and improvement on your measures. So it looks like you haven't even hit the asymptote of your dose response curve. And that's over the time period that presumably over a year the disease is progressing. So what's going on? In other words, that you showed a few little microstructural changes and stuff, but is that really the explanation for the continuing dose effect that you're seeing? I mean, what do you think is going on?
Yeah, so that's a very good point. Thanks. So I think that's just one piece of evidence, but clearly I mean, more broadly, these effects could actually involve remote connection, could involve rearrangement of synaptic activity, local circuit level, neuron level. I think that the complexity is very big, and we need to make a big effort to collect as much as data we can in order to try to understand better what's happening. So I agree with you, it's still complicated to give a proper answer to this question. Yeah.
Thank you. So I think we can move. So Giacomo, please, can you please join us sitting, and then we will have opportunity to a larger discussion at the end. So now we are moving to other type of clinical domains. So we are moving to anxiety and depression. So it's my pleasure to invite Professor Arianne Gravesteijn to join us at the podium. So the title of your presentations beyond medication. So the role of, you are now kicking out, physicians, the role of exercise and other non-pharmacological interventions in managing anxiety and depression in neurodegenerative disease. So welcome, please.
Yes, hi everyone, and thank you for this very nice introduction. I know my name is a bit difficult always. I'm honored to present here today on anxiety and depression in people with neurodegenerative disorders and the potential role of non-pharmacological treatment interventions, and particularly exercise therapy. I don't have anything to declare. And first of all, I would like to explain some of the definitions that I will be using during this presentation. First of all, depression is a common mental health disorder which is often associated with low mood, loss of interest in daily activities, the feeling of worthlessness, sleep disturbances, fatigue, difficulty in concentrating, and in some cases also suicidal thoughts. And these symptoms can significantly impact the quality of life in people having depression. Anxiety is a natural response to stress, and it is characterized as a feeling of worry, tension, fear. And when these feelings persist or impact daily living, it becomes an anxiety disorder. And anxiety disorders can lead to emotional symptoms like worry, panic, restlessness, but also physical symptoms such as heart palpitations, shortness of breath, muscle tension. And these chronic, overwhelming feelings of anxiety also impact daily functioning and quality of life. And anxiety and depression often co-occur, and they often occur in people with neurodegenerative disorders. And today I will focus on especially multiple sclerosis and Parkinson's disease, two neurodegenerative disorders which are mainly characterized by motor symptoms. So in Parkinson's disease we have rigidity, tremor, bradykinesia, and freezing of gait. And multiple sclerosis is known for its loss in muscle strength, sensory loss, and ataxia. But also non-motor symptoms such as anxiety and depression often occur in people with these diseases. Current pharmacological treatment interventions for anxiety and depression and multiple sclerosis often have limited efficacy and are not always well tolerated by the people with neurodegenerative disorders, also because they also have other treatments for the neurodegenerative disorders, so there's a complex polypharmacy there. and there is thus a pressing need for other non-pharmacological interventions intervening on anxiety and depression. And recently this review came out that investigated the effects of non-pharmacological interventions in people with Parkinson's disease, and this study demonstrated that especially depression has been studied extensively. As we can see by the straight lines, there are a lot of treatment options there: cognitive behavioral therapy, non-invasive brain stimulation, exercise, light therapy, electroconvulsive therapy. Anxiety has been studied less extensively, but there are also indications that cognitive behavioral therapy is effective, and there are also indications for non-invasive brain stimulation and exercise. In multiple sclerosis, it has been studied less extensively, but cognitive behavioral therapy is also effective to treat both depression and anxiety in people with multiple sclerosis, and there are also indications that non-invasive brain stimulation and exercise therapy are potential treatment options for people with anxiety and multiple sclerosis. So exercise is frequently mentioned and has also been studied extensively. But first, let me explain something about exercise for those of you who don't work with exercise therapy. Exercise therapy is just physical activity which is planned and structured, repetitive, and is often prescribed by a healthcare professionalist such as a physiotherapist. And the aim of the intervention is to improve physical fitness or overall health. And in neurodegenerative disorders, exercise has been studied extensively, and we already know that this is a safe and feasible intervention. It is furthermore used to the improvement of symptoms. It can improve muscular strength, cardiorespiratory fitness, balance and coordination, just mobility, balance, but also improve daily activities and quality of life. And the Cochrane review, this Cochrane review with meta-analysis also indicated that several interventions which included exercise interventions, different types of exercise interventions, the more commonly used interventions such as endurance training and resistance training, but also dance interventions and gait and balance interventions improved impairment in people with Parkinson's disease, and it also improved the quality of life in these people. This has also been shown for people with multiple sclerosis. And for multiple sclerosis, we also know that exercise has a beneficial effect on muscle function, cardiorespiratory fitness, and also on quality of life, both mental and physical quality of life. So now let's discuss the role of exercise in alleviating anxiety and depression. Also, in Parkinson's disease, there has been a lot of research in the field of depression, and this meta-analysis demonstrates that specifically general exercise, endurance training, and dance interventions were effective to alleviate depression or depressive symptoms. In multiple sclerosis, we see similar findings. Exercise also has an effect on alleviating depressive symptoms. Anxiety has been studied less extensively, as shown in this meta-analysis, only including 2 studies which seem favorable towards the exercise intervention to reduce anxiety in Parkinson's disease. And this has also been shown in people with multiple sclerosis. So, interestingly, exercise may also influence neurodegeneration, the topic of this whole conference. And exercise has the potential to impact neurodegenerative processes that also contribute to to anxiety and depression. So neurodegeneration or neurodegenerative disorders are characterized by, for example, brain atrophy, neuroinflammation, mitochondrial dysfunction, oxidative stress, reduced growth factors like brain-derived neurotrophic factor or vascular endothelial growth factor. And these processes can also play a role in the existence of affective disorders such as depression and anxiety. And they can also influence the HPA axis, which is also really known for its role in mood disorders. Now, how can exercise influence this? This is a rather difficult graph, so we'll go through it. So exercise has been shown to play a role in the upregulation of several growth factors, such as vascular endothelial growth factor, which is might indicate an upregulation of angiogenesis within the brain. So there might be an upregulation of oxygen supply and nutrition within the brain. It can also result in an upregulation of brain-derived neurotrophic factor, which is linked to neuroplasticity. Exercise can result in an upregulation of mitochondrial biogenesis, which might reduce the oxidative stress and oxidative damage. Exercise might also influence the inflammatory status by directly influencing pro- and anti-inflammatory cytokines, but this can also be through the glucose metabolism. And furthermore, there are also indications from animal studies that exercise might affect the microglia, and the more anti-inflammatory cytokines are being upregulated, while the pro-inflammatory cytokines are being downregulated. So there are a lot of indications there. So to summarize for this point, exercise is a safe and feasible intervention for people with both Parkinson's disease and multiple sclerosis. It is effective to improve motor symptoms, quality of life, and there is also a lot of indication that it's effective to improve depression. Furthermore, there are indications for the effect of exercise on anxiety, but that's something we need to address further, and we also need to look further into the disease process and the effect of exercise on this. So, to look forward, there are key areas where the future research is urgently needed: exercise and anxiety, the coupling between exercise interventions, anxiety and depression, and neurodegeneration. And there are also different exercise modalities. So which exercise intervention is the most effective, efficient, and feasible to guide future therapies? Building on our previous research, we focused on two primary exercise types, which are endurance training and resistance training. And in the Exercise Pro-MS study, we, for example, examined the effect of progressive resistance training on neurodegeneration markers. In the Trayvon's aerobic training study, we also investigated people with multiple sclerosis, but then the effect of an endurance training intervention. And in the Hit the Track study, we investigated two types of endurance training: continuous aerobic endurance training and high-intensity interval training in people with Parkinson's disease. Now, here I want to show you two examples of training interventions at our center. The video shows a group of people with Parkinson's disease engaging in high-intensity interval training, while on the picture on the left you can see a MS patient performing progressive resistance training on a leg press machine. And these examples highlight the variety of training methods we are exploring in our studies. And the Trayvon's aerobic training study was actually a secondary analysis of blood-based biomarkers, and in this study we looked at brain-derived neurotrophic factor, which was hinted upon previously, but we also looked at neurofilament light, a marker of axonal damage within the nervous system, and also glial fibrillary excitic protein, of GFAP, which is a marker of astrocyte activity, and in multiple sclerosis strongly linked to disease progression. And although we didn't find any significant findings in this study, we did saw a decrease in GFAP concentrations and NFL concentrations after the exercise intervention, which weren't present in the control group. We are currently analyzing MRI data and blood-based biomarker data from the Exercise Pro-MS study. That was a within-patient study, so all participants performed 16 weeks of baseline, continued by 16 weeks of progressive resistance training, followed by a 16-week follow-up stage. And during every measurement stage, we measured neurodegeneration with the MRI, blood-based biomarkers. We also investigated daily functions, muscle strength and cardiorespiratory fitness, but also cardiovascular risks. And these results will follow soon. And in the Hit the Track study, we compared two types of intervention, as I mentioned, continuous aerobic training, which involves a longer session at a low resistance exercise. And it is often prescribed to people with neurodegenerative disorders because it's rather simple, and it's also very safe and effective, but it can be very time consuming and a little bit boring for people performing it. On the other hand, we explored the potential of high-intensity interval training, which is alternate short burst of high-intensity exercise with a recovery period. And high-intensity interval training is way more dynamic. And the total duration of the intervention is way shorter because the overall intensity of the intervention is higher. And exercise of also high-intensity interval training has proven to be safe in people with neurodegenerative disorders and also effective to improve cardiorespiratory fitness, where an endurance training intervention is focused on. But there's also indications that it is effective to impact growth factors. Here is a small overview. So this was a single subject design with a crossover. So all participants were randomized at the start of the study and then were randomized into the order of the interventions. So everyone started with the baseline intervention, then or started in the high-intensity interval training group or the continuous aerobic endurance training. Then there was an 8-week washout, and then they did the other intervention followed by an 8-week follow-up. And we measured disease severity, measured by the Unified Parkinson's Disease Rating Scale. We also measured cognitive function, depression, and blood-based biomarkers. And here I want to show some of these results. And we can see here two different participants. On the right side, we see the blue participant, and on the left side, we see the red participant. And the most, the graph A, let me find out this, yeah, here. This is the UPDRS part 3, and this is the part 2, and the difference between these two parts is that 3 is determined by a rater, this healthcare professional, and the other is from the participant itself. And as you can see, there is these dots and the lines, and the dots present the raw scores, the lines present the improvement, and we also see these triangles, and the triangles indicate the smallest detectable change. So a change larger than this triangle indicates a relevant difference. And as we can see, for participant, the blue participant, we can see improvements after the continuous aerobic endurance training for both scales, and also after the high-intensity interval training. This is a bit different for the red participants. We see an improvement in the rated scale after the continuous aerobic endurance training, which is not present after the high-intensity interval training. And the self-rated scores, there was not a lot of difference, but a bit of a deterioration after the high-intensity interval training. And these findings already highlight there is a difference between people. There is a lot of variability in these study results. We also looked at depression, and as we can see here, it's actually the same kind of graph. We see that the blue participant improves after the continuous aerobic endurance training, but deteriorates after the high-intensity interval training, and these findings were not replicated for the red participant, but that might have to do with the fact that the participant didn't have any depression to start with. We also looked at brain-derived neurotrophic factor, and as we can see, we measured it actually more often. We measured this weekly, and as we can see here, the blue, oh, sorry, that was the wrong one. As we can see here, the blue participant reduces BDNF concentrations after the continuous aerobic endurance training, but improves after the high-intensity interval training, and an improvement is the thing we want to see. For the red participants, we see an improvement after the continuous aerobic endurance training and after the high-intensity interval training. But also here a lot of variability. So we have to study this more extensively on a larger scale. And that's what we're currently doing. We are currently conducting a larger scale study, the HERSEN-FIT study, which is translated to English as the BrainFit study. And here we include 48 people with multiple sclerosis or Parkinson's disease, and they are randomized in either movement advice, continuous aerobic exercise, or high-intensity interval training. And our primary outcome measure there is anxiety and depression, but we will also examine blood-based biomarkers of neurodegeneration throughout the study, and we will perform this weekly. We will also conduct MRI measurements, and we do this all together to gain more insights into the patterns of change. We will measure anxiety and depression, and the study aims to advance our understanding of how exercise can address both mental health and neurodegeneration in these populations. And before I conclude, I want to acknowledge the invaluable contribution of our research teams and collaborators who made this study possible, and thank you all for your attention. I look forward to discussing these results.
Thank you, Arianne. Just one question, one focused question. Yeah, there, please.
Hi, beautiful talk, Arianne. Lucia, University of Florida. I'm wondering if you've thought about any of like digital biomarker readouts. There's a lot of interest in that because it's reporting a lot of different things, especially for the Parkinson's patients. And maybe you will get a little bit better picture of compliance and all that if some of the exercises is not being done at the center.
Yeah, so in these studies we conduct a lot of the interventions at our study center, so we have like a real good idea of the adherence and compliance of these interventions, but we also have the movement advice group, and this group wears a smartwatch during the whole period, so we have this information. Yeah, thank you.
Thank you. So, Arianne, probably I would invite you now to sit, and then we can open. We have 15 minutes, so we have time. We can really have a fruitful discussion. So, while you are thinking on your questions, I will start, and I will start saying that again, everything makes sense, and probably everything works. Exercise, modulating risk factors, doing TMS. The problem is the magnitude of the effect. It's for such a severe neurodegeneration clinical outcome. So that's why I think we are all discussing about multimodal interventions. We are thinking on different single intervention, but multimodal. But my question is, it's your vision for the future, and we are also working on even changing the urban space. This is something that we are working with the Fundación team. So, what do you think it will be able to implement? What will be your definition of multimodal? I would say for the next 10, 15 years. Probably we will run to work using an helmet, doing TMS during that way, and of course controlling for risk factors, all those things. So what's your vision? How these things will be packaged regarding something that is feasible, implementable, and with a magnitude that it's just more than just a little signal. So probably, Pablo, I will start with you, and then we can rotate. But please, try to be focused, just to open then the discussion to all. So Pablo, first you. Can we switch on the? Use this one.
Thank you. Yeah. Okay. So thanks for all your comments and the question. I think we have to think that the future is now. And I'm saying this because the only way we can face these disorders, and I'm talking about cognitive disorders mostly in Alzheimer's, is from the prevention scope. So I think we would all agree that there's not much to be done delaying the diagnosis until persons are dependent and so on. So from the preventive point of view, I think that we should start acting early in the sense of promoting risk factors control, in the sense of promoting healthy lifestyles, healthy diet, things like that. So all I'm saying is something that we all know.
Yeah.
Taking care of oneself is good. The thing is, do we know how we should take care of ourselves? I think that's the big question. And that is why we are doing our study. And most of the fingers studies are being done. Because we all know that taking care of risk factors and lifestyles and so on is good, but we don't know how to do it. There's a philosophy in the design of finger studies, at least in our finger study, in our CITA GO-ON study, in the sense that the intervention that has been designed, in the case it shows efficacy, it should be easily translated into the health systems. So we are not using sophisticated machines for exercise. We are not using computer-based, sophisticated cognitive training strategies. We might have to include transcranial stimulations, but I don't think that's complicated. So we all have thought that in the case this is efficacious, it would be easily translated. And then, in the long continuum, where personalized and precision medicine start to take place in our hands, not in our computers, in our hands. We have to control for all this. My vision of the future is someone who gets her risk factors early detected, early treated, and then there will be markers, blood biomarkers that will tell, we'll find those people in whom control of risk factors and lifestyle habits have not been efficacious. They're starting to deposit amyloid or to have tau normalities and so on. And those are the ones that should go to have anti-tau therapies, anti-amyloid therapies and so on, acting early. So that's my vision. Prevention in a continuous way, in a continuous fashion.
Thank you.
It's easy to say, difficult to show.
Difficult, yeah. Giacomo, how can we bring, TMS to the full population? It's below.
Yeah. Okay. So, thank you. So it's a big challenge, of course. What we are showing is rather preliminary, and now the focus is trying to actually make these things more automatized and available to non-expert people, because that's the big step we have to do, and the challenge we are facing, and of course needs a lot of research and investment, but I think it's definitely doable. And regarding the future, I agree with Pablo. The future is now. I mean, it's happening, and by the way, I mean already with drugs, everybody now speaks about combination therapy. Nobody still thinks that one drug may solve the problem. And we might extend this concept. Combination therapy is not only a combination of drugs, but it's a combination of drugs and non-pharmaceutical approach. We are not saying that these are two different things. They need to be together. And so I think the scenario is quite complex, but all these voices need to be put together for the benefit of the patients.
Thank you. Arianne, for you, I changed a little bit my question, because one of your slides is the reason why we should move to exercise. It's because drugs are dangerous. They have undesirable adverse events. I need to tell you that people fall. Exercise also may be dangerous. But the main problem about exercise is adherence. How can we convince our patients? And this applies to all. Adherence. Like if we have a pill, we may have an amazing pill. If patients don't take it, no benefit. So how is it possible that my patients, that they say, Professor, I will do it. And then we know that, that after, 2 or 3 days, they stop it. They say, I have already registered in the gym. The registration per se makes nothing, you know? So how can we, you know, overcome that very human limitation that it's adhering to something that, you know, requires effort?
Yeah, that's a very interesting question, actually. And that's something I struggle with myself as a physiotherapist. When I get exercises from my physiotherapist, I won't do them at home. And I think a lot of people don't do that. And I think one of the problems there is that the exercises that are given to participants are often boring and not the exercises they want to perform. But I think we have to look for interventions that are focused on their own interest. And I don't think it's really important to perform like 3 times a week, 50 minutes continuous aerobic endurance training. I think it's important that people perform their physical activity in a manner they have fun in. So I think that's one of the main things to improve that. And another point is, I think that the whole system is not really focused on being physically active, as we all sit here today, the whole day, and yesterday the whole day. There is not the focus on being active. So I think that's something we should focus on.
Thank you. So, yeah, Marcel there. Can you bring the microphone there?
Thank you. Thank you, and thank you for your talks. My question comes from a place of lack of knowledge. In fact, it comes from a place of ignorance. But when we think about classical pharmacological approaches, right, we have a theoretical model. Even Giacomo, when he was presenting his TMS approach, he was coming from a theoretical model. But as a physician, as a researcher, sometimes when I think about more behavioral interventions, right, and sometimes it's like the problem is this, so the PD patient is falling, we know that we want to reduce risk factors, but how do you design interventions? How can we start thinking better on how to design behavioral interventions, the active element of the intervention? Am I making, maybe you have some insights about that, Arianne?
Also a very interesting question. I think there is an important role there for a physiotherapist who can help, and I think it's mainly guided based on the needs of a person. So if a person wants to walk better, yeah, usually we do something like gait training, and it depends on the problem. But the interventions we are talking about now is more like general interventions at improving cardiorespiratory fitness or muscle strength. And the idea is that it sets emotion pathways that impact like neurodegenerative pathways as well. But this is a field which is not really totally discovered yet. So at this point, we just don't know which type of intervention is the best, and we see indications from several types of interventions that might be effective, and maybe a combination of interventions. But the main thing is there, if you want to improve these things, I think it's very, very important that, yeah, same story, that people can continuing doing this, because if they do this for like 12 weeks, it's nice. But I think you have to maintain these interventions to get a better effect or maintain the effect. So if the intervention is really nice for someone, they probably will continue with it. But if it's boring, it's not into their interests, it's not a favorable exercise, yeah, they will just stop. So I think it's important to think of that as well.
Pablo?
Yeah, interesting question. If our intervention is efficacious, I think that some of the key points of the success will be, first, that the intervention is person-centered. So it is the individual that decides to participate in the study, that decides to take care of himself or herself. So it's not the physician, the priest, or the major that tells him or her to take care. It's a personal decision. But the other crucial point to me is the fact that most of the intervention is administered in groups. So the sociability aspect, the sensation of being integrated in a group, in the community, and doing things that are good for the individual, but also for the group as well. I think that's going to be one of the of the key points of the success, if we are successful at all. And this is also telling us that when we translate the intervention to the health system, I think it will have to be the health and social system. So I don't think this is something to be done at primary care centers, but rather at community centers. Something that comes from the community to the people, something that is designed and carried out by the people, not the authorities, so to speak.
Thank you. Yeah, please.
Just to contribute to the discussion, which I think is really key, as Joaquim said, it's not enough to sign to the gym. I mean, it's really much more complicated to build a habit. And I think that in these trials, in these interventions, the methodology of building a habit should be really, you should really focus on that. Not only on, it's not that it's fun or social, that's, and it's beneficial, but really, you know, there are a lot of methods that can help people to really build a habit, to make it a long habit. I don't know, helping them to do it methodically, helping them to remember when to start the habit. You know, there are many tricks that maybe you should incorporate. I don't know if this is already in the methodology, but I think probably you should really focus on that because I think it's essential.
Yeah, I think you're right. We insist a lot that the objective of the intervention and the study is to change habits. Somehow we tell them that this is for 2 years, but if they change their habits, they will maintain this for as long as possible. And as you said, changing habits includes not only going to the gym, but also using the stairs instead of the elevator when you're getting home or you're getting to work, going to places walking and not by car, things like that. This is something we have to insist, not only from the physical and motor point of view, but also from the cognitive point of view. Teaching people how, when they are making their grocery shopping list, when they are going to somewhere and deciding I'm going to take this road or this other road, being conscious that those are cognitive activities that their brains are doing, I think it will be very important to change habits from the physical and motor point of view, but also from the cognitive, and even more with the control of emotions, the control of stress, the solution to the non-wanted loneliness and things like that. So that's changing habits, absolutely.
Thank you. So, yeah, very short, very focused, please.
Very short. The big elephant in the room, and I mean big, is that nobody has mentioned diet. And we know that you can't exercise your way out of a bad diet. So how do we actually integrate that into the framework, both for prevention and for progression?
Yeah,
very in the spot. Please, no, please.
Yeah, I think you're right. Diet and nutrition is one of the key points of our intervention. And as I said before, it's not only a question of giving lessons of what's good and bad. It's a question of having fun cooking, having fun having meals together. That's the point.
Thank you. So having the prerogative of being the chair, now I can close. I can just make a comment. It's not just diet. It's many other things. Some we know, and many others we still don't know, and those are the, you know, the more problematic ones. Just as a sign of alert, this is for today. 2% of the Portuguese population are demented nowadays. Probably the Spanish numbers will be similar. In 30 years, 4% will be demented, and then we need people to take care. So 8–9% of the people in 30 years will be or demented or taking care of demented. So this is a very serious health problem, public health problem. So this is, I would say, a society problem. But coming back, we are giving the wrong signals. We are retiring people. At the age of 65, 70, at least in Portugal, we are sending people home. They don't work. They change habits for the worse. So, you know, as a society, we are not learning, even if we are not treating the diseases as much as we would like today. We are not even learning to do things that probably would prevent in some way using the society as our, I would say, experimental model. So thank you very much. Thank you for your question. Thank you for the CIN Foundation, all the organizers. Thank you. Thank you very much.
Thank you.
So we should run now. We should go out of the room running and doing exercise, you know, to lunch. Thank you.
Thank you, Joaquim. Thank you, everyone. Lunch is being served right outside these doors on the first floor and the top floor. I kindly ask, however, those that have poster presentations that go to the exhibition hall. Those that have poster presentations, please go to the exhibition hall. Thank you. Enjoy lunch.